Hello everyone. Welcome to the official channel of Index Department of Physiotherapy and Biomedical Sciences. Today we will be discussing about scoliosis. Let's move forward to the introduction. Scoliosis is defined as a lateral deviation of the normal vertical line of the spine below the 10 degree, associated with the rotation of the vertebra. Three-dimensional deformity of the spine, sagittal, frontal, and coronal planes. 2% of children are affected at some stages of life. 10% of affected patients will require corrective surgery, occurring 1 to 3% of the population below the age of 16 years. 0.1% have a curve greater than 40 degrees. Girls are mostly affected than the boys. Those with a curve of more than 30 degrees are generally girls, outnumbering boys by 10 raised to 1. The ratio is for the girls are 10 and 1 raised for the boys. Moving on to the anatomy, all bony elements are altered. Vertebrae are wedge-shaped, poorly developed concave side. Pedicles are rotated. Discs are wedged as well. As here you can see, the spinous process is deviated to the concave side. The lamina, thinner and vertebral canal narrower on the convex side, rib pushed laterally and anteriorly. It is the concave side, and this one is the convex side. The ribs are pushed posteriorly and thoracic cage narrow. As you can see here, the deviation in the spine. Moving on, yeah, to the diagram. As you can see, the lateral curvature to the right side is a normal spinal cord that is vertical going downward. As you can see, the lateral curvature. As here you can see the gap between the facet. Moving on to the etiology. The general causes are strongly familiar. 11% incident in the first relative of the patient. Tissue deficiencies common in the Marfan syndrome. Growth abnormalities are asymmetrical vertebral growth, central nervous system alteration, different size cerebral cortices, associated rings, low-lying cord, Arnold-Chiari malformation, functional spinal cord tangent. The clinical types are the structural and non-structural scoliosis. Structural scoliosis involves both the lateral curvature of and rotation of the vertebra. Non-structural includes the spine has a lateral curvature, but there is no structural abnormality in the spine. The curvature is in response to habit or a disease process. As you can see, the structural scoliosis are congenital scoliosis. It is caused by bone abnormality present at the birth. Neuromuscular or myopathic scoliosis, result of abnormal muscles or nerves, frequently seen in people with spina bifida or cerebral palsy, or in those with various conditions that are accompanied by or result in the paralysis. Degenerative scoliosis result from traumatic injury or illness, bone collapse, previous major back surgery, or osteoporosis. Adult scoliosis that typically occurs after 65. Idiopathic scoliosis, most common type and no specific unidentified causes. There are four types of scoliosis: infantile, juvenile, adolescent, and adult. Infantile affect at the birth and 3 years old. Juvenile in pre-puberty 3 to 9 years old. Adolescent puberty to maturity 10 to 18 years old. And adult after the maturity after age of 18 years. Moving on to the non-structural scoliosis or postural or the functional. A reversible lateral curvature of the spine that tends to be positional or dynamic in nature. No structural or rotational changes in the alignment of the vertebra. Disappears when the patient is in supine or prone or sitting. Correction of the lateral curve is possible by forward or side bending. This test is done to determine whether the curve straightens or out as the children bends forward and identify a visible rational deformity of the rib cage. We will be seeing the test which used to correct the spinal correct curvature. Moving on to the positional changes and alignment of the pelvis or spine, muscle contraction by correction of a leg length discrepancy. As here you can see, is an erect posture of a non-structural scoliosis. You can see it is bending at the right side, lumbar curve correct and therefore non-structural. Thoracic curve persists and is therefore structural. Non-structural scoliosis are of furthermore types. Postural, this curvature is due to prolonged use of a wrong posture. It resolves when the children lies down. Compensatory, it is caused by leg length discrepancy. There is no rotation of the vertebra and is usually goes off on sitting. Sciatic, this curve results from trying to avoid pain from a irritated sciatic nerve. Inflammatory, here a curvature in the spine is caused by an infective process such as appendicitis. The body curves in response to the disease or abdominal muscle spasm. Hysterical, very rare and has an underlying psychological component. Now moving on to the classification. Here we will be seeing the cervical curve. It is present at the apex between C1 to C6 vertebra. Cervicothoracic curve apex between C7 and T1. Thoracic curve apex between T2 and T11. Cervicothoracic curve is present at the apex between C7 and T1. Thoracic curve apex between T2 and T11. Thoracolumbar curve is present at the apex between T12 to L1. As you can see, the lumbar curve is present at the apex of L2 to L4. The lumbosacral curve between the L5 and S1. As you can see in the King's classification, the double curve, both curve cross the midline. The lumbar curve larger, stiffer than the thoracic curve. The double curve both cross the midline. Thoracic curve larger, stiffer than the lumbar curve. As you can see, the thoracic curve crosses the midline and lumbar curve does not cross the midline. As here you can see the long thoracic curve in which L5 is centered and over the sacrum, but L4 tilts into the long thoracic curve. At last, you can see the thoracic curve and T1 tilts to the upper curve. As you can see, the Lanke's classification are of six types. Type 1 are the non-structural, type 2 structural, type 3 non-structural, type 4 is structural, type 5 and 6 are again the non-structural. Main thoracic are structural major, 4 of them. In the non-structural structure, the curve type are main thoracic, double major, triple major, thoracolumbar. As here you can see the criteria. Now moving on to the diagnosis. History, first noted on progression. Family history affected siblings 7 times more frequent, affecting parent 3 times more frequent. Recent growth history, sexual maturity, pain, fatigue pain, post-diagnostic pain, or severe pain. Physical examination can be done by iliac crest height, LLD, that is leg length discrepancy, shoulder height, arm trunk space, capillary position, the trunk shift, the tilt, the neurological examination of muscle charting, generalized features as the Marfan's syndrome, inspection of the skin as capsulate spots or hair patch. As here you can see if there is an uneven shoulders, We can rule out the ligament discrepancy, and there is a curvature in spine. As you can see here, the uneven hips that might be causing an LLD. You can see the uneven shoulders, which causing a tilting of the vertebra to the right side. Next up, the Adams forward bend test. As you can see, the patient is moving forward, bending down, touching to the toes. We can see the alignment of a normal spine. And here, as you can see, the scoliotic alignment, which shows a curvature and hump at the right side. This is all about Adams forward bend test. Moving on to the scoliometer. It is a device used to measure the scoliosis or the curvature of the scoliosis. 7 degrees, below than 7 degrees is a normal curvature that can be treated with exercises and rehabilitation. Now, moving on to the radiographic evaluation. Posterior, anterior, and lateral radiographs, right and left bending films, traction films, fulcrum, bending films or push-prone radiographs, flexibility. Stagnara, it eliminates rotational component of the curvature. Radiographic parameters to assess the maturity. Hand and wrist are development of the iliac apophysis, riser sign, triadiate cartilage, olecra, non-apophysis ossification, and the digital ossification. Moving on to the Cobb's angle, it is used to evaluate the curvature of the spine. As you can see, the Cobb's angle, the curvature, we start from where the tilted vertebra above the apex and the most tilted vertebra below the apex. As you can see, the parallel lines from these tilted vertebrae produce an angle which is known as the Cobb's angle. As you can see, the mild moderate severity as classified. The treatment on observation, moderate, watchful, halting or bracing, severe in surgery is required. Next up, the vertical rotation, Nash and Moe, as you can see. The riser grade is used to see the skeletal maturity based on the ossification of iliac apophysis, graded from 0 to non-ossification to 5, completely bony fusion. MRI report shows that the neurological deficit necessary in case of a thoracic curve to the left, painful scoliosis, abnormal neurological finding, excessive stiffness, deviation to one side during the bend test, sudden rapid progression of a previously stable curve. Progression curves 30 to 50 degree progress an average of 10 to 15 degree over a lifetime. Curves more than 50 degree at maturity progress steadily at a rate of 1 degree per year. Curves less than 30 at bone maturity are unlikely to progress. At 90 degrees or greater, increase the potential for life-threatening effect on the pulmonary function. The treatment can by observation, bracing, and surgery. As you can see, the riser state 0 to 1, 0 to 1 curve, 0 to 20 degree, 20 to 40 degree are observed and brace is applied. 2 to 3, 2 to 3, 0 to 30, 30 to 40 are observed and brace is applied. 0 to 3, 0 to 4, more than 50 degree and higher are required the gray surgery. As you can see, the infantile scoliosis curve may disappear by itself as age increases. A Milwaukee brace full time is used at 24 hours. Surgical correction. Juvenile scoliosis by use by Milwaukee brace 18 to 24 hours. With reduction of curve, time of wearing also reduced from 20 to 6 hours every day. And surgery is required in juvenile scoliosis. Adolescent scoliosis curve under 45 degree, exercise, bracing, electrical stimulation, manipulation, biofeedback. Curves over 45 to 50 degree are required surgically. Bracing Orthotic bracing 64%, 74% success rate at halting progression. Must be worn 20 to 23 hours a day. But most patients are not compliant. Braces do not correct scoliosis. Contraindications: curves below than 450 degree, patient with noticeable trunk shift, skeletally mature adolescent riser 4 to 5 2 years post-menarche, curved apex about 26, excessive thoracic hypokyphosis below than 200. As you can see, the Milwaukee brace and the Boston brace to correct the curvature of the spine. Surgery required are the spinal fusion, motion segment vertebra are welded together using bone graft, rod and screws, posterior approach back, thoracic curves, anterior posterior approach front and back, anterior approach front, thoracic lumbar and lumbar curves, a thoracoscopic surgery, VATS, a video assisted thoracoscopic surgery, spinal instrumentation without the fusion. As you can see, the scoliotic spine. Spinal fusion, the steel rods are applied to help support the fusion of the vertebra. Bone graft are placed to grow into the bone and fuse the vertebra. Spinal fusion procedure. As you can see, the surgical procedure correct the posterior approach required in patients with double or triple curves or curves. As you can see, the scoliosis correction through the posterior approach. Anterior posterior approach performed in patients with severe stiff curves and in young skeletally immature patients to prevent crankshaft phenomena, progression and rotation of the curve resulting due to growth and the anterior part of the spine and fused to posterior part. Anterior approach are thoracolumbar and thoracic curves. Growth rods, commonly used in children, allow for straightening of the spine and subsequent lengthening procedure until the patient reaches adolescence when a spinal fusion procedure is performed. Thank you. This is all about scoliosis.